Hello there, it's Luke, and in this session we're going to be thinking about hypovolemic shock, and we're going to be exploring the causes of hypovolemic shock and also looking at how the different physiological processes and the loss of fluid itself manifest as the different clinical signs that you may see in practice. Okay, so very simply, we previously thought about shock and about how it's a failure of blood supply to the tissues leading to altered metabolism, and it's a failure of oxygen, a failure of nutrients getting to the tissues, and a failure also of removing things like carbon dioxide and toxins away from the tissues and preventing their build-up. And thinking specifically about hypovolemic shock, put very simply, there's not enough fluid in the system. So first of all, why is there not enough fluid in your system, within your vessels and being pumped around your body by your heart? Well, you could be bleeding. You could have had trauma, road traffic collision, for instance. You may have had a fracture, and fractures will bleed a great deal as well. It might be surgical bleed. It could be a GI bleed, either melena out of your back passage or hematemesis, so blood being vomited up, which can occur with people with sort of liver failure, for instance. Similarly, you can have gastrointestinal losses, and unfortunately we've all been on the rough end of a diarrhea or vomiting bug in the past, especially those of us that have worked in healthcare and witnessed the joy that is norovirus. Similarly, you may have a decreased intake. You may not be able to get sufficient amount to drink, particularly thinking about maybe hospital inpatients that have been NG fed and the feed has been turned off for a while, or dependent on IV fluids, or somebody undergoing chemotherapy that just doesn't have that hunger or that thirst in quite the same way. And lastly, we can think of those patients that may have excess loss through urine. So they may be taking diuretics, so water tablets, things like furosemide and benzoyl-thiazide, and they may be losing a disproportionate amount of fluid in their urine. Similarly, patients with people with diabetic emergencies can also lose a lot of urine as well, can cause them to become incredibly hypovolemic. So we said that there's not enough fluid in the system. But thinking about it more technically, what we're really talking about is a decrease in venous return. So there's less fluid coming back to the heart. There's less fluid coming back to the right side of the heart, and therefore less fluid coming to the left ventricle. And this will have a huge impact on your cardiac output and your stroke volume. And of course, when we've thought about the left ventricle being less full, we're really considering a decrease in preload. And you'll recall that preload is this idea that the more you stretch the heart muscle, the more you stretch the left ventricle, the greater the force of contraction. Whereas if you've got less fluid coming back, if you have less preload, then actually there's going to be less contraction and a smaller stroke volume when the heart beats and ejects blood from that left side of the heart. And if we go back, we've got this relationship between how full the left ventricle is, so the left ventricular end diastolic volume, and the force of contraction or the stroke volume that's ejected each time the heart beats. And in a healthy individual who's well filled, you can see that actually the left ventricle is nice and full, and so the force of contraction and stroke volume are going to be good. In somebody who's hypovolemic, the issue is that the left ventricle never really sort of fills sufficiently to have a good contractility or a good stroke volume. And this is the main issue that we see with hypovolemic shock. So we've explained there that we've got a decrease in preload, which leads to a decrease in stroke volume, a decrease in cardiac output, which you'll recall is the amount of blood that is ejected from the LV within a minute. And so consequently we have a drop in blood pressure, which then has a knock-on effect in terms of perfusion and how we reduce perfusion. So what clinical signs might you notice or find in a patient who is hypovolemic and has all those compensatory mechanisms, things like the barareceptor reflex and the renin-angiotensin aldosterone system, all come into play to try and compensate for that loss of fluid. We may have thought of some of these things. So you might have an increased capillary refill time. The patient might have fast heart rate, might have a tachycardia. That pulse, when you feel it, might be very weak or thready, as it's often sort of written in textbooks. They might have very dry mucosa or sort of reduced turgor, so the skin doesn't spring back in quite the same way when we're assessing our patient. And they may also have a change in their respiratory rate, so they might breathe faster or deeper. In the case of patients with a diabetic emergency. So what are the physiological processes that are underlying these clinical signs? So if we think first of all in terms of our capillary refill time, so we're used to doing that, okay, for a few seconds and then releasing, seeing how quickly the skin goes from being blanched, which is white, to being pink again. Well, there's a lot of your compensatory mechanisms ultimately lead to a lot of vasoconstriction to improve the systemic vascular resistance, and this may be because of direct nerve impulse on the blood vessels themselves. It may be that there's been an increase in adrenaline and noradrenaline being released from the adrenal glands, and similarly there may be angiotensin 2, which is also a very strong vasopressor, which has been released as part of the renin-angiotensin aldosterone system. And all these things will vasoconstrict at the peripheries. You'll get these cool peripheries with a prolonged refill time that we see in shocked patients, or rather in hypovolemic shocked patients. What about the fast heart rate? Well, you'll recall that the barareceptor reflex senses there's stretch sensors in their aorta, and when they're less stretched, then there are fewer impulses that travel up to the brainstem, to the medulla oblongata. And based on this and other stimuli, this reduces the vagal nerve stimulation of the heart. And what the vagus nerve does, you'll recall, is that the vagus nerve acts like a brake on the heart to slow down the heart rate. And so when you've got somebody who's hypovolemic, and you have that reduction in stress, so there are fewer messages going to the brainstem, and then there's that sort of release of the brake, so there's less impulses travelling down the vagus nerve, you consequently get a raise in heart rate, and you get this sort of tachycardia. Now, if you recall sort of from previous teaching sessions, we looked at the pressure volume curve, and here it is, and you'll recall that between points A and B, when the mitral valve's open, the left ventricle can fill. Now, and we call that sort of difference between the amount of blood that's in the left ventricle at the beginning of that fillings phase and the amount of blood that's in there just as the heart begins to contract and the mitral valve closes. That's your stroke volume. And similarly, when the heart contracts and the aortic valve opens, we get this ejection phase. And as you'll recall from that previous teaching as well, the point at which the aortic valve opens is our diastolic blood pressure when we're thinking about pressures, and the sort of peak pressure that reaches during contraction is our systolic blood pressure, and our pulse pressure is the difference between those. When we have less venous return because we've lost fluid or not managed to take enough in, we have a reduction in that stroke volume, and consequently you can see with our pressure volume loop here, there's also we've not got the same preload, and there's a reduction in the pulse pressure because of that, and we would experience that as a weak and thready pulse. Now, we mentioned in our sort of list of possible symptoms there, or signs rather, a reduction in skin turgor. So we might say that this patient's arm is, the patient is dehydrated, and you can see where it's been pinched just at the top there. Then the skin has sort of stayed put, whereas I'm not as dehydrated. If I do that, it instantly sort of disappears. And An explanation for this, going back to our thinking about tissue fluid, is if we consider the capillaries. So we've got these semi-permeable epithelial sort of lining of the capillaries. So this is within the intravascular space within the blood vessel, and then there's the fluid within the tissues itself in the interstitial space, and there's this constant tension between the Starling forces, so the hydrostatic pressure, which is related to the sort of blood pressure, which is pushing the fluid out of the blood vessels, out of the capillaries into the interstitium, and there's the oncotic pressure from the proteins within the blood vessel that is drawing the fluid back in. Well, if we have a drop in blood pressure because of a loss of fluid, a hypovolemia, then our hydrostatic pressure will be reduced. But the oncotic pressure doesn't change, so actually you get an imbalance in those Starling forces, and fluid is drawn in as a compensatory mechanism drawn in to the intravascular space, and it leaves the interstitial space. And we would be able to identify this as less fluid within the tissues, and that decrease in fluid within the tissues would lead to a decrease in skin turgor that we're seeing there. Finally, and I only want to mention this very briefly because we'll discuss this more in a subsequent tutorial, is one of the compensatory mechanisms that your body has for the altered metabolism causes a drop in pH, which makes your blood more acid. Now, one of the ways that your body tries to compensate and tries to make the blood less acid is to breathe out carbon dioxide. And so you get a change in both the respiratory rate, someone might breathe faster, we call that tachypnea, and they may also breathe very deeply, so bigger volumes that they're breathing out and getting rid of that carbon dioxide, and in doing so trying to rebalance the acidity of the blood that is being caused by the sort of altered metabolism due to the shock state. But we'll talk about this more in subsequent tutorials. So to sum up, we've highlighted the causes of hypovolemic shock. We've discussed how hypovolemia results in reduced venous return and hence reduced preload and stroke volume, cardiac output and blood pressure, and ultimately reduced tissue perfusion. And then we've explained some of the physiology behind many of the signs that we see in clinical practice, such as cool peripheries with prolonged refill time and tachycardia and those sort of things. We've described how they will work with the physiology that we've learnt to date. That's the end of the session. Thank you very much.